So, welcome back, everyone. I hope you enjoyed some networking and opening the boxes. Last week, I had the pleasure of meeting with Professor Lucy Chappell to record an interview for today's symposium. As you will know, Lucy recently took up her new role as Chief Scientific Advisor to the Department of Health and Social Care and Chief Executive of NIHR. As you will see in the interview, it includes some reflections from Lucy on the challenges of the pandemic, the contribution of the CRFs, and on priorities for clinical research, including the role of CRFs as we move forward. I hope you enjoy it. So good morning, everyone, and a very warm welcome to Professor Lucy Chappell, who's joining us this morning. Huge congratulations on your appointment. Perhaps I could begin by asking how you feel your own career and experience to date has prepared you for taking on such a challenging and important role.
Well, thank you very much for that introduction, Chris, and for the invitation here today. So I'll start with just talking a little bit about this role and where my career has, how that's landed me here. So I'm Chief Scientific Advisor to the Department of Health and Social Care and Chief Executive of the National Institute for Health Research. The CSA role is one of a number in government. So there is a chief scientific advisor in pretty much every government department now, with the Department of Health and Social Care role being a fairly chunky one. And the CSAs are headed up by Sir Patrick Vallance, who is government CSA. So what that reinforces is that we have the approach is to have science and evidence underpinning government policy across all government departments. In my case, this comes with Chief Executive of the NIHR, as you know, biggest health funder in the UK. And it's enormously helpful to have the budget that the NIHR has in order to enact that provision of research and evidence into government policy and for the wider benefit, obviously, of patients and the public. So my career path has really been as a researcher and a clinician. I'm a professor of obstetrics and a consultant obstetrician based at King's College London and Guy's and St Thomas's. And I've kept those roles on at 1 day a week because I think it is really helpful and important to understand what is happening more at the coalface of academia and in the NHS. And they're a big part of my identity to date. I've had a career through sort of clinical academic research that's spanned many parts of that translational pipeline, or as I prefer to see it, a translational circle, including from some earlier phase work through implementation and with a bit of policy work to think about the whole of the research landscape. It's a big step from coming from a more conventional clinical academic role into what is a civil service role and into very much more of a role where you interact with the civil service and government on a daily basis. But I'm really committed to seeing how researchers can interact more with policy and practice in this area. So hopefully interesting times to come, I'm sure.
Absolutely. So looking back over this very challenging last 18 months, what would be your reflections on the role of the UK in combating the COVID pandemic?
I think it's clear that in many areas, particularly from the research perspective, we've really been a world leader, and that's recognised by many other countries who ask what did we have that enabled us to step up so ably. So I think that's largely as a result of the prior investment into people, into the infrastructure, that collective collaborative expertise, the NHS that enabled much of that research to be rolled out. And that's matched by the response of the public and sort of the NHS and social care professionals all coming together to make that happen. And that really started with the invention, the making of the National Institute for Health Research, which has seen that research budget and delivery ring-fenced such that when we needed in a pandemic, we saw so many people step up to enable many aspects, from the recovery trial to the vaccines trial to many other studies that have played their part in really moving us through this pandemic and to where we are today. And I think now we just need to think about how we really capitalise on that and move forward.
Absolutely. So it's now 20 years this year since the 5 so-called Millennium CRFs in Birmingham, Cambridge, Edinburgh, Manchester and Southampton opened back in 2001. The network of CRFs has expanded dramatically, however, since then, so that, as you know, we now have 22 NIHR CRFs in England, but more than 50 in total across the UK and the Republic of Ireland. I wonder what your thoughts are on this remarkable growth and on just where we would have been had we not had these facilities embarking on dealing with the COVID pandemic.
Yeah. I mean, I think I'm clear on this. CRFs have been a really crucial component, firstly for the development of experimental medicine in the UK, and particularly prior to the pandemic, and then really how they've stepped up through the pandemic, particularly for sort of delivery of the novel COVID interventions, vaccines, therapeutics, and through really different and flexible ways of working. And I think that applies both to the NIHR CRFs, but also to the much wider field of CRFs across the UK. I'm aware that many CRFs provided really important support for the urgent public health badge studies at pace, and that they really embodied this sort of partnership approach for patients, healthcare professionals, and for working with the life sciences industry. And as I say, that predates the pandemic to a way of working that had already established all of those components and then pivoted very effectively into being a crucial part of that pandemic response. One of the strengths, I think, is the links with many different parts of the research ecosystem. So, for example, with the BRCs, onwards into later phase trials. And I think that's reflected in the very strong sort of leadership and engagement, both sort of internally with parts of with the CRF workforce and with the public, as we saw in terms of how they responded to that public willingness to take part, and really with a lot of their external collaborators as well.
Absolutely. So building on that, as you said, there's a long and proud history of CRFs working collaboratively together and with other parts of the infrastructure to ensure we're at the forefront of experimental medicine internationally. As you've also said, the last 18 months have really put that into the spotlight. So how do you think we can build on that positive experience going forward?
I think what I see is that the CRFs offer a model of working that is already tried and tested, and I think it's a sort of relatively mature model of working. It's still, there's still evolution of, as there should be, but we should reflect on that 20-year history, and I think that sort of strong collaboration tells us where things are working. So I think that experience, where do we go from here? Well, we've got the Recovery, Resilience and Growth Model programme, and I think all of those apply definitely to the CRF. And I think we need to look at how we return to core business, but in a more agile and sort of learned way. So how do we retain the best parts of learning from the pandemic, and then retain those with better working practices, but move back into sort of the core business of experimental medicine? I reflect on lessons from that have arisen from the CRF. For example, having an amber area for COVID-19 follow-up was a really sort of innovative way of not having a no entry here for COVID follow-up, but thinking of imaginative ways of handling that. And other examples, for example, where there's been coordination of diagnostic interventions or blood sampling across studies rather than having a very siloed way of working. Where do I think we need to continue this work? I think addressing the health inequalities that have been pervasive is a real opportunity that CRFs have already started with, and all of us across the NIHR are going to see more of that, quite rightly so. And I think looking at the strategic focuses that we have in the NIHR, so for example, I'm interested in how the experimental medicine community think about further development of work with patients who have multiple long-term conditions. previously, we've sort of taken a view that early phase work might be focusing on, for example, those just with one disease, and that patients with multiple long-term conditions may so-called sort of muddy the waters, but they're real people, real patients, real conditions. And I think I'm really interested in and doing work with other parts of the experimental medicine community to say, how can we better adapt both in research design, delivery, analysis and interpretation in this area. I think there's definite interest in saying, how do the CRFs continue to think about reaching underserved populations? This isn't new for them, because I know that there's plenty in this area already. But how do we as a sort of funder and research delivery service think about reaching those with the highest health needs, sometimes when that feels like more work, but that's where the need is. And to come back to, why does all of this matter? Because it's better science. It's better science if we find research for all, not just for a select few.
Absolutely. So you've identified some highlights and strengths in our response to the COVID crisis. Do you have any insights of how we might learn from what we might do better if there were ever another health crisis of this scale?
Yes, and I think we can reflect on what went well and then where we would adjust. So I think what I have seen, and I was part of for a large part of the pandemic, was a sort of real system approach to this very rapid sort of upscaling and delivery of research, because we had that prior investment and where the CRFs, really played their part. And with the regulators, there are all these components of the system that need to work, pull in the same direction, and to come back to that again, that buy-in from patients and the public. What do I think we could adapt and adjust? I think there are some aspects of the funding model that needed tweaking. There's a huge amount of work that went into both the funding review and the prioritization, and I've heard that some bits of that just need some tweaking. I think it's been very challenging to balance the needs of COVID studies with other research, particularly as the pandemic wasn't a 3-month event. It's been longer than that, and that is an ongoing challenge. And I think there are some examples of where CRFs did adapt. So, for example, in early phase oncology trials, where they did reopen and enable some really important offering and delivery of research in that space. I think we're learning that it's much easier to turn off the tap than to turn it back on. So we saw what happened in the early stages of March 2020. And now what we have all been grappling with is, how do we restart that process? That communication, constant communication, is so crucial. And I come back to something that is very close to a lot of our hearts, which is it's sort of nurturing the workforce. Because I look at where we are, the enormous amount of work they've done through this 20 months, and now we're asking them to recover and rebuild and grow, and how looking after the workforce is so important as well.
Yes, perhaps to build on that, clearly the success of CRFs, you said it yourself, is principally down to its workforce. And so how would you and your colleagues help to further develop the expertise, the resilience, which has been demonstrated very remarkably over recent months, and perhaps in particular the career development of all colleagues in all different professions associated with the delivery of experimental medicine? And linked to that, greater and further integration of clinical research into the core activities of the NHS, which has again been evidenced, I think, over the last 18 months.
I think that's so important. So workforce development needs to be everyone's business and not just for a select few. And sometimes we've started with sort of pathways that may feel as if they've been a bit selective. But we're only as good as our workforce, whether that's recruitment, retention. So for me, a strong workforce is multidisciplinary, multi-layered, and we need to think about how we recognise and support people across that workforce. And it's not just, for example, a medic-centred offering. And so we need to think about, what does that look like? For example, if you're part of the CRF delivery, those people have got as many career needs as anyone else in the system. And I think at NIHR, we are really starting to look at, in more detail and depth, at what our offering is for the delivery workforce, recognizing that they may have a complete breadth of needs. Some are very happy, competent in that research delivery role, but we should ensure their ongoing professional development. But some want to use it as a stepping stone to other parts of the academic pathway. So the key is to sort of think about what it is that enhances recruitment and retention to enable that sort of very coherent career structure and development and those opportunities coming in and out, and also to think about a flexible model alongside partner NHS trusts. I'm not trying to poach NHS staff, I'm trying to offer opportunities for them, and that should be bi-directional. So I think we have to work with our NHS trust to make sure that there's that mutual trust and an understanding of how do we work together in that space.
Absolutely. You mentioned earlier on the importance of the life sciences industry, and again, the last 18 months has epitomized how that working together is so important. What do you think the role of CRFs per se in working with the industry is going to be going forward?
I think CRFs have already got a clear track record in working with industry, and it is one of the strategic focuses of the NIHR that I am very clearly signed up to. And I think there is much that we learn from the CRF model of working with industry that we build on for the wider research ecosystem. And I think we listen to what has gone well for CRFs and recognise those strengths that exist. And we are aware that needs to be a transparent model, because there is still some resistance in some areas or some caveats, concerns. But I think the CRFs are leaders in this area, and therefore we reflect on how that relationship is built and developed. We know that industry in particular are keen to continue their core business their business in the UK. I spoke at the CRN and industry conference a couple of weeks ago and heard that from across the industry sector, particularly around what the UK offers through parts of the research ecosystem like the CRFs, and also recognising the diversity of the UK population that is very relevant from the industry perspective. So I think as long as it's underpinned by that collaborative, transparent way of working, there is a very strong future for CRFs within the NIHR and wider afield, working with industry as it relates to the pharma sector, but also to other areas, devices, diagnostics, us thinking of industry in the very broadest sense and not in a narrow sense.
Thank you. So, having been in this new role for just a few months now, I wonder what your broad vision for the next few years for clinical research in the UK would be.
Thank you. Shortly before I started in August, the strategy document, Best Research for Best Health, the next chapter, was published, and I'd had sight of it. And I think it gives us a very clear roadmap of where we need to go with this. So it sets out 7 strategic focuses that really address a key concept, which is thinking about how we improve the health and wealth of the nation, and really ensuring that we think about health inequalities and how we tackle those, because they were present before the pandemic, but they've really been amplified by the pandemic. So the sort of 7 areas which are applicable, all 7 of them to the CRFs, are thinking about the recovery, which we've talked a bit about, and thinking about how we work both in the short term for recovery, but also with a longer term sort of horizon. Thinking about that capacity and capability, and that is in 3 areas: preventative, public health, and social care research. So the CRFs might think, well, what's in it for them? But actually, particularly around that preventative piece, I think there's clear work that the CRFs can be engaged with. I've mentioned improving the lives of those with multiple long-term conditions. And I think this is potentially a really exciting area for the experimental medicine community to consider, to think about how they embrace that and make their offerings relevant to those groups. This isn't new to the experimental medicine community in any way, but I certainly think we can all think from, as I say, from design, but also some of the methodological issues around that. And again, well placed to address that. The fourth focus is on underserved regions and those with major health needs. There are CRFs across the UK and Republic of Ireland with reach both locally, often to very diverse populations, and also potentially further afield. And the new ways of working that we've seen that the CRFs take on is very relevant to saying, how do we reach those with health needs, particularly the underserved, and just thinking how we as both funders and sort of research deliverers go further, sometimes with a bit more work, but more reward, because it will be relevant to the populations. The fifth is about ED&I, equality, diversity and inclusion. And that's relevant from both angles, both as the workforce in CRFs and the participants. And it is a virtuous circle. So just all of us asking ourselves, how do we promote that principle? You mentioned strengthening careers, and I think we are seeing this shift from strengthening careers for just a narrow part of the workforce to a much broader offering. And again, it doesn't have to be top down. I think this can be a real bottom-up approach with CRFs to say, what would that look like built from the CRF community, not just imposed from above. The people at this meeting are going to know exactly what their needs are, and it's a question of facilitating that, not just telling, doing something to the CRF community, but asking for it from the CRF community. And the last one is working with the life sciences industry. And as I say, I think CRFs are an exemplar here of how that model works and works well. So I've kept those 7 strategic focuses because they are directly applicable to where we are at the moment. They work for everyone, or should be working for everyone. But we've also just got to think a bit about new challenges. And I'd mentioned, for example, climate change. So how do we address both the health impacts of climate change, but how do we ask ourselves, what does research delivery look like if we wanted to become more sustainable? And again, CRFs have given us examples of where they've taken that on and already thought about better ways of working.
Fantastic, thank you very much. So I would like to thank you very much for joining us this morning. It's been a delight to talk to you. It's great to hear that working together between the CRFs and the NIHR and yourself in the leadership role will be strengthened going forward, and I'm sure we would very much welcome working with you to further develop the role of the CRFs in the delivery of experimental medicine. I don't know whether you have any final comments, but mine is to thank you.
Well, thank you, Chris. And I think it's given us an opportunity to sort of cover areas that I hope will be of interest to your audience. I'm out and about visiting slowly once things opened up again come September. So I would really welcome the opportunity to, and I tend to get out of London for my visits, although I do have a CRF on my doorstep, but also to sort of hear from first hand what it is like. And so typically on visits, I like to hear from early career researchers or those doing research delivery, not just at all from the shiny professors, lovely as it is to meet shiny professors. So I would really welcome the opportunity to do that, because what I find is that being on the ground sometimes often gives me insights that you sort of get from being up close and personal. And I think that's going to be the right way to tackle where we are, the challenges, but really building on such strengths that existed before the pandemic. And I think the CRFs should be really proud of how they have adapted. And for this community to ask themselves, where do they retain the best bits, and think about moving forward. And I hope that some of the answers today have given everyone a sort of a sense of where I see us as the funder and a sort of responsible for this part of the infrastructure, where I see us heading.
Thank you very much, Lucy. And on behalf of the CRF community, I'm sure we all wish you very well in your new role.
Thank you.